you. I request the moderators for the second session, Professor Rakesh Kochir and Dr. Naresh Bhatt, to please take over. Please.
Thank you, Ajit. After a lot of deliberation in the first session, we have something equally interesting coming up in the part 2 of today's program. And to present these abstracts, I'll invite Dr. Saurav Kedia, who's an associate professor at All India Institute of Medical Sciences at Delhi. And Dr. Naresh Bhatt is going to be co-moderating this session with me. And we have three eminent panelists, Dr. Desai from Bombay, Dr. Rupa from Hyderabad, and Dr. Takanori Kanai from Japan. So I invite Dr. Kedia.
Ash, can you please put on the slides?
Good evening, everyone. First of all, I would like to thank Professor Sood and Professor Ahuja for this opportunity given to me. And I'll now continue on with the rest of the abstracts. So I'll start off with the IBD pot theory, and the first abstract was related to post-operative recurrence of Crohn's disease. So this was titled as a normogram incorporating neoterminal ileal and anastomotic lesions separately is accurate to predict the long-term outcome of Crohn's disease after ileocecal resection. This was from China. So we all know that the red blood score is the most frequently used score for predicting post-op recurrence of Crohn's disease. It has been modified by dividing I2 category into two types. The I2A when the lesions are confined with the allocolonic anastomosis, and an I2B when there are more than 5 ulcers in the neoterminal ileum. However, the significance of isolated and anastomotic recurrence still remains unclear. So the question asked in this study was, can a separate scoring for both ileal and anastomotic lesions, that if both were considered together, can predict long-term outcomes better after surgery in Crohn's disease. So we aim to develop a normogram model incorporating ileal and anastomotic lesions to predict the long-term outcomes of Crohn's disease after resection. The study design is not clear from the abstract. Patients with conservative or patients with Crohn's disease post-ileal evaluation with post-operative colonoscopy were included. The endpoint was post-operative clinical response, and endoscopic classification depending both ileal and anastomotic lesions were applied, and in normogram from both perspectives, the accuracy was evaluated by ROC analysis. There were 191 patients. Post-operative relapse was seen in about 2/3 of patients over a median follow-up of around 2 years. So the clinical relapse was higher in both ileal lesions versus no ileal lesions and anastomotic lesions versus no anastomotic lesions. And on multivariate analysis, the independent factors of recurrence were female gender, non-colonic Crohn's disease, and ileal as well as anastomotic site lesions, and the accuracy of this normogram was 0.7. So these were the features of the normogram, and the authors concluded that the normogram incorporating post-operative ileal and anastomotic lesions separately could predict clinical relapse in CD patients better than the red blood score alone. The second abstract was from India, from NATSAKE by Dr. Savan Bopana, which looked at the role of motorized spiral enteroscopy in the evaluation of isolated small bowel Crohn's disease. We all know that small bowel evaluation is required in patients with suspected small bowel CD. The evaluation is limited by the balloon enteroscopy, and the spiral enteroscopy can shorten the procedure time and visualize the entire small bowel. So the authors try to look at the impact of NMSC in patients with suspected small bowel Crohn's disease and evaluate the diagnostic and therapeutic values in suspected small bowel Crohn's. The retrospective study, which included patients with suspicion of isolated small bowel Crohn's disease between March 21 to February 22, both integrate and retrograde procedures were included. So total of 30 patients were included. The most common clinical examination was pain abdomen, and the most common indication was abnormal CT or MR, followed by abnormal capsule endoscopy. So total of 53 procedures were performed in these 30 patients. The procedural success rate was around 80%. Total endoscopy was done in 13 patients, and therapeutic procedures were done in 8 patients. The impact was evaluated at 6 months of follow-up, and it was seen that about 60% patients had newly diagnosed with Crohn's disease and were treated with the appropriate treatment. One patient had a localized picture and underwent surgical resection. CD was ruled out in 3 patients, and tuberculosis was confirmed in 2 patients. So overall, impact was seen in 29 out of 30 patients, and 8 patients underwent structural dilatation. So the authors concluded that in patients with solvable Crohn's disease, NMSC is useful tool in establishing a different diagnosis of Crohn's disease, the ruling out Crohn's disease, and differentiating it from tuberculosis. So the third abstract is from Korea, which looked at the significance of periappendial inflammation in patients with ulcerative colitis. So the periappendial inflammation can be seen in about 6 to 25% patients with left-sided colitis or proctitis. However, the prevalence and clinical significance of periappendial inflammation in ulcerative colitis remains unclear. So the authors tried to answer the question whether the long-term outcome differs between patients of UC with and without PAI, and the aim was to identify the clinical significance of PAI in UC. It was a retrospective cohort study which included patients of UC with E1 or E2 disease, and the patients are divided into PAI and non-PAI groups, and the demographic features and clinical course of two groups were analyzed. 107 patients were included, roughly 56 with E1 and 52 with 42, 1 with E2, and about the same number had 52 had periappendial inflammation and 55 did not have. The baseline features were comparable. Follow-up duration 51 months, and at the end of follow-up, the outcomes in the form of relapse rate, treatment escalation, and proximal disease extension, as well as the cumulative relapse rate 1, 3, and 5 was similar between the two groups. So the author concluded that PAI diagnosis did not affect the course of disease in patients with E1 or E2 disease. The fourth abstract looked at the real-world effectiveness of budesonide versus prednisolone for ulcerative colitis. This was from Taiwan, and we all know that budesonide has been utilized for induction of remission in mild-moderate UC, which is refractory to 5-HA therapy, and it is also commonly used in combination with other therapies. However, its use pattern compared to prednisolone remains unclear. So the research question was, is there any difference in the use of prednisolone versus budesonide in patients with ulcerative colitis? So it was again a retrospective cohort study which included patients of UC treated with budesonide or prednisolone, and their demographic features and clinical features, disease course and concomitant therapy were recorded. 28 patients received prednisolone, 19 received budesonide. The baseline characteristics were comparable except for the partial motor force and higher with prednisolone, and the past prednisolone which was prednisolone used, which was again higher in the prednisolone group. So the outcomes of budesonide, the mean duration of treatment was 1.8 months, and the common indications included alternative use with steroids or biologics, partial response to previous therapy, and clinical relapse. And if you look at the effectiveness of budesonide therapy, so about 1/3 at clinical remission, half had clinical response. So a total of 50 to 85% patients had either response or remission. So the authors concluded that in real-life clinical practice, budesonide is commonly used in combination with other therapies in multiple UC patients, and effectiveness is comparable to other studies. The fifth abstract was a multi-center study which looked at the challenges of implementing T2T strategy in patients with inflammatory disease from Asia Pacific, Middle East, and Africa. So STRIDE 2 has recommended T2 target approach for inflammatory disease. However, implementation is challenging both at physician and patient level. So this study aimed to conduct a survey to better understand the key challenges in adopting the T2T approach in the Asia Pacific, Middle East, and the Africa region. So a structured survey of 10 questions was sent to 19 early specialists from 14 countries, followed by 300 roundtable discussions. And the questionnaire explored current practice, preference for treatment options, diagnostic and monitoring tools, and the major desirable improvements. So if we look at the challenges, the four most important challenges were the adherence to treatment, limited availability of non-invasive tests such as fecal calprotectin, lack of remote disease monitoring tools, and the lack of trained IBD nurses. And the measures to improve suggested were more access to the ultrasound, availability of fecal calprotectin and its low cost, artificial intelligence assisted diagnosis, and smart phones for disease monitoring. So the authors concluded that the key identified challenges were the lack of general practitioner awareness, limited access to IBD trained nurses, patient adherence to disease monitoring using biomarkers, and the affordability of fecal calprotectin. The sixth aspect was from India, which was a randomized controlled trial titled Potassium-Rich Diet, Coconut Water, Modulates the Gut Microbiome, and Induces Clinical Remission in Patients with Mild to Moderate Ulcerative Colitis. So, high potassium intake has been associated with a decreased risk of IBD. Urinary potassium levels have been correlated with the disease activity in ulcerative colitis, and gut microbiome modulation is associated with improved outcomes in ulcerative colitis. So, the hypothesis for this study was whether coconut water as a high potassium diet and a microbiome manipulating diet could improve the disease activity in ulcerative colitis. So the aim of the study was to evaluate the effect of coconut water as an anti-inflammatory and microbiome manipulation therapy in inducing benefit in patients with multimodal symptoms. So for the open label, randomized, placebo-controlled trial, which included patients with mild to moderate endoscopically active ulcerative colitis. The patients were randomized into two groups. The coconut water group received 400 ml of coconut water daily with the standard medical therapy, and the placebo group received 400 ml of water with standard medical therapy. And the patients were evaluated clinically at 2-weekly interval and with endoscopy and fecal catheter at baseline and 8 weeks. So both clinical remission as well as response were significantly higher in the coconut water as compared to the placebo group. The endoscopic outcomes were also higher, but the difference was not statistically significant. Proportion of patients with fecal calprotectin less than 150 was again higher in the coconut water group. The gut microbiome was also modulated positively, and there was increased abundance of bacteria, which is a negative correlation with disease activity in the coconut water group. So, to conclude, coconut water increased reductive protection, modulated the gut microbiome, and was more effective than placebo for induction solution in patients with mild to moderate disease. There are two abstracts which looked at the metabolomics. One including both artificial intelligence as well. This abstract was from China, a novel serum metabolic panel for the diagnosis of Crohn's disease. So metabolomics is basically the analysis of entire metabolic profile in a biological sample. It could be blood, serum, urine, or stool, and it could be the metabolite could be host-derived, diet-derived, bacterial, or modified bacteria. The metabolic profile of Crohn's disease differs from the healthy controls and other intestinal inflammatory disorders. So the authors asked whether the serum metabolites can be used for diagnosis of Crohn's disease, and they tried to identify the serum metabolic signature for diagnosis of CD and differentiated it from healthy controls, TB, ulcerative colitis, and basic CD. It was a cross-sectional study which had two cohorts. The developmental cohort included patients with treatment-naive Crohn's and healthy controls, and the validation cohort included Crohn's disease patients, healthy controls, UC, TB, and basic disease. The metabolomics was done with the LCMS platform, and the author did a univariate analysis, discriminant analysis to cluster the metabolites, and ROC analysis to calculate the accuracy. There were 185 metabolites which were quantified, of which 5 were significant to distinguish Crohn's disease from healthy controls. And for disease activity classification, the accuracy was comparable to CRP and ESR, and it was also significant in differentiating from other intestinal disorders. So a combination of 5 serum metabolic parameters could be an accurate, non-invasive alternative for the diagnosis of Crohn's disease and differentiated from the other intestinal inflammatory disorders. The other abstract used both metabolomics and machine learning to identify the signatures of ulcerative colitis with the classification according to the disease extent. So we all know that the fecal metabolite profile is different between ulcerative colitis and healthy control, and it can also differ with respect to the disease phenotype. So the research question was, does the serum metabolite profile in patient with UC differ with respect to disease extent? And the study aimed to identify the serum metabolic profile of patients with different disease extent. So again, a cross-sectional study, including patients with ulcerative colitis and healthy controls. This study also used the LCMS techniques for the metabolite dissection, and again the discriminant analysis for metabolite clustering, and the machine learning tools used were the lasso regression and the support structure machine feature elimination. So on the OPLS discriminant analysis, there were metabolites which were different between healthy and ulcerative colitis, E1 versus E2 disease, E1 versus E3 disease, and E2 versus E3 disease. And on application of machine learning algorithms, 11 metabolites were confirmed with an AOC was of 0.7. So there were significant differences in the metabolomics among UC patients with different disease extent, which should be used as biomarkers to predict this population. The other aspect related to machine learning was related to differentiated Crohn's disease and systemic disease, which is a very common problem for us. So this study used an AI-based multi-parametric model to differentiate Crohn's disease from intestinal tuberculosis. So it had 25 patients with TB, 57 with Crohn's disease, of which 54 were included in the training and 28 in the testing cohort. So it had a multimodal information, including 3 clinical features, 21 MRE features which were extracted through radiomics, 5 colonoscopic features which were again extracted through radiomics, and 4 pathological features which were extracted through deep learning. Following this, the authors did a feature selection and dimensionality reduction through univariate analysis, feature extraction and selection, and convoluted neural network and principal component analysis. And finally, the features were combined. The features included the clinical features, the T1 and the magnetization transfer MR radiomic features, photospecific features, and the deep learning features for pathology, which were then combined, and the random forest classifier was utilized to calculate the diagnostic accuracy. And it had the multidisciplinary model had an excellent diagnostic accuracy in both the training as well as the testing cohort. And this was significantly better than the individual MRE, colonoscopic, or pathological or clinical models. So the last section is related to the gut microbiome. So we all know that gut microbiome signature is different between patients with IBD and the healthy control. There are different niches for the gut microbiome. Most commonly studied is the lumen or the fecal microbiome and the mucosal microbiome, which include the bacteria which are close to the mucosa. Mucosal microbiome is less well characterized as compared to the fecal microbiome, and microbiome may also differ with respect to different disease phenotypes. So this study compared the characteristics of segmental mucosal microbiome according to the extent of inflammation in the collective. This was from Korea. So the research question by the authors was, is there any difference in the mucosal microbiome profile for each segment of the colon according to the extent of inflammation? So they included two features, the colonic segments and the presence or absence of inflammation or the extent of inflammation in patients with ulcerative colitis. So the aim was to find the differences in the mucosal microbiome according to the colonic segment in patients with proctitis, left-sided colitis, and remission. So they had 28 patients with UC, of which 18 had proctitis, 4 had left-sided colitis, and 6 were in remission. And microbiome was evaluated in cecum, descending colon, and rectum. 16S RNA analysis was used, and alpha diversity, abundance analysis, and beta diversity was done. So in patients with active inflammation, that is proctitis and left-sided colitis, the alpha diversity was higher in rectum and descending colon than cecum. The bacterial profiles were also different, and beta diversity was also different with respect to segments. However, in patients who were in remission, there were these differences were lost, and alpha diversity, composition, and beta diversity were similar across all the segments, concluding that mucosal microbiome differ between inflammation and remission with respect to the disease location. This second abstract looked at the gut microbiome and clinically stable ulcerative colitis according to the colonic mucosal state. So the question was, does the composition of gut microbiome of UC in clinical remission differ according to the mucosal state? The author aimed to investigate alteration in the gut microbiome according to starring changes in the colonic mucosa among patients with UC in clinical remission. So there were 57 patients of UC in clinical remission, of which 29 had a normal mucosa, that is complete mucosal lining, and 28 had altered mucosa, that is advanced scarring and inflammation. There were 57 healthy controls. Fecal microbiome was analyzed again with the 16S RNA profiling. So it was seen that on alpha diversity analysis, the alpha diversity for patients of UC in clinical remission was lower than that of the healthy control. So even in clinical remission, their alpha diversity was low. And also, this diversity was not different between with respect to the mucosal states. So the third abstract was again looked at the mucosal microbiome in patients with ulcerative colitis, and they looked at the difference between the inflamed and the non-inflamed colon. This was again from Korea. So the research question was, does the mucosal microbiome differ between inflamed and non-inflamed areas of colon in UC? And the aim was to characterize the mucosal microbiome in patients with UC and to investigate the association with salivary and fecal microbiome. So there were 5 patients of ulcerative colitis, and the samples were stool, saliva, and pathological testing for the mucosal microbiome. Again, this testing is RNA sequencing. So the mucosal flora of inflamed and the non-inflamed region was slightly different. E. coli, Escherichia, and Shigella were abundant in the breast samples of inflamed colon. The fecal microbiome was similar to the breast microbiome of the inflammatory lesion. However, the oral microbiome, though was most diverse, there was no association with the bacterial or the mucosal or the fecal microbiome. So again, to conclude, compare the fecal samples, endoscopy brushing or mucosal microbiome could be used as a diagnostic test to reflect the mucosal ulcerative bacteria. And the last abstract related to gut microbiome was from India, which was titled Explosive Enteral Nutrition, Gut Microbiome, and Corticosteroid Response in Patients with Acute Severe Colitis. So this was a post-hoc analysis of our previously published RCT, which showed that the exclusive enteral nutrition augments the response to IV steroid in patients with ulcerative colitis, and microbial modulation by EN could be one mechanism. So the research question was, does EN alter the gut microbiome in AOCC? And also, does the baseline microbiome correlate to the IV steroid response? The study aimed to identify the EN-driven gut microbial alterations in patients with AOCC to examine the correlation with clinical parameters and also to identify the baseline microbiome signature which will predict IV steroid response. So the patient was AOCC who received EM and steroid and who received steroid alone were included. Fecal sample was collected at baseline and day 7 and 15S RNA gene sequencing was done and compositional analysis, beta diversity experiment correlation was done. So if you look at the first aim, then the microbiome at day 7 was different with respect to day 0 in EM responders versus non-responders. So at the day 7 in patients who responded to EM, there was upregulation of healthy bacteria such as Faecalibacterium, Legionella, and there was downregulation of bad bacteria such as Pseudomonas and Klebsiella. And this was reflected in the clinical correlation. So the bacteria which were upregulated such as Faecalibacterium and Legionella had a positive correlation with serum albumin, whereas the bacteria which were reduced such as Pseudomonas had a positive correlation with the inflammatory markers such as day 5 CRP. And again, and also at the baseline, there were certain bacteria which were upregulated in the responders, and there were certain bacteria which were upregulated in the non-responders. And the baseline microbiome signature had a reasonable diagnostic accuracy to predict the IV steroid response in patients with acute severe ulcerative colitis. So to conclude, augmentation of clinical response by EM conjugated corticosteroid therapy is accompanied by specific microbiome changes in patients with acute severe ulcerative colitis. So I would end now and open the house. Thank you.
Thank you, Saurabh. We have very little time left, unfortunately, but just few things, comments. One is a lot of these papers had to do with the microbiome and things like that, which is not really into hardcore clinical practice. So I just make two comments. One is, first, the Spirus paper by Dr. Savan Bopanna, interesting, but the whole spiral endoscopy is in a state of coma. We don't know whether it will get revived. We'll forget about it for the time being. The nomogram for the ideal lesions, Rutgers scores for the nomogram showed an area under the curve of only about 0.7. So I don't think it's anything spectacular that we can use in daily practice. I think coming to the more specific questions, I would think the more relevant question for the Indian audience would be the use of budesonide. I found that interesting that it was useful, but maybe I can ask Rupa, what are your thoughts on the MMX budesonide? Do you find it useful? Does it take a little longer time? And is it as good as prednisolone in our Indian patients?
It's a very good question, and there is no one word answer. But if there was a very severe disease, I would go for prednisolone, but the disease is more moderate. And for a patient, that if I feel that we can wait, I'd rather go for budesonide because of its safety profile. If I'm giving, say, a biologic which may take some time, then rather than adding steroids to it, maybe I will add budesonide. So in general profile, this gives us one option between mesalamine and steroids, and full-fledged steroids. How far the efficacy is? Generally, there is symptomatic response, definitely, but long-term is what we have to see.
Devendra, your thoughts on how long does it take for the effect to last? We see the prednisolone acts much faster. Does budesonide MMX do the same? What are your thoughts, and how often do you use this in preference to prednisolone?
So basically, as Rupa mentioned, I position it between 5-ASA if they are not responding in mild to moderate ulcerative colitis. Before giving prednisolone, I use budesonide MMX. I typically give about 4 weeks for it to act. And if it is useful, then we can continue for a longer time. We know that in the response that we expect is approximately 17% from core 1 and core 2 study. And in the study that was presented, it was 31%. So we know that is the response, and we should be prepared for that response.
Rakesh?
I think I would go and give standard prednisolone in a patient who requires anything beyond 5 ASA rather than there's no definite evidence that it works as fast as prednisolone. It definitely takes a longer time, and I'm skeptical about its overall effect also. Even in autoimmune hepatitis, it has limited role. So that is the nearest corollary in which it is used by a gastroenterologist. So I would like to know what others actually practice.
The other thing about, maybe I can ask Devender, do we have a Japanese colleague? I don't see him on the screen. He's here? He's not there. Okay. The use of the microbiome manipulation for your study is fine, but how often are you using fecal microbiota transplant in day-to-day clinical practice? And if so, what are your hard indications? Devender first and then Rupa.
So basically, it is not in the routine use. We have used it in the past, mainly in patients with mild ulcerative colitis, because most of the literature says that we should use in moderate to severe ulcerative colitis not responding. We have used it initially. Recently, as you know, we had a conference in Ludhiana where we discussed the details about it. Including that we need to have some sort of authorization and procedures. So yes, we have used it. Literature says that the utility is about 24 to 28% as compared to 9% placebo, but we don't know where to place it as of now.
Would you like to take that, Dr. Sood, Ajit?
Yeah, thank you. Can you just comment on budesonide first? Because we are using budesonide quite regularly. And for patients with mild to moderate disease, before starting prednisolone, we always use budesonide. And at times, if patient is going to be on TOFA, as Rupa mentioned, or other biologics or small molecules, if we combine the two, the action is better. With availability of budesonide MMX, our use of prednisolone, I would say, has drastically gone down.
I think I'll completely agree with what Dr. Sood is saying, because it gives us one more option. So it of course has to be clinically, case to case basis. If I see a severe disease, then of course we'll go for prednisolone because the side effect profile is much better. And so sometimes even mesalamines, and if you give budesonide with it, in that 2 months, mesalamines also act and things may improve. And if it doesn't, you always have the option of stepping it up.
I'm going to ask a very question to all of you. You've got an MMX preparation, right? So it requires some amount of technology to it. So are all MMX preparations the same, or do you find a difference between the 2 or 3 ones that are available in the Indian market? It's a little provocative, but I want an answer to that.
Not really compared to comment. I mean, it's not say. I just want. We have not really compared. I can't say on this.
Okay, so we don't know.
To make one comment, Professor Kochhar mentioned that this doesn't work, may not work in alcoholic hepatitis. He's right. In patients with cirrhosis, if hepatitis and cirrhosis element is there, then in fact we should avoid budesonide because it loses its advantages. Its metabolism becomes different. And it loses its advantages. So in patients with cirrhotics, we may not use budesonide.
Harish, on this issue, I think is it a question of semantics? It doesn't give us another option. It is a steroid, non-systemic. So the effect is the same. The dose is, you have only limited dose schedule 963, and I have seen patients with severe ulcerative colitis.
It's only 9. It's only 9.
Yes, only 9. So I've seen patients with severe ulcerative colitis, moderate to severe Crohn's disease, being prescribed budesonide. That would not be fair. So it cannot be, allowed to be used indiscriminately. We should put a rider, and as such, yes.
Correct. Is the inappropriate use, we're mixing up the small bowel delivery versus the large bowel MMX. I think that's something which a lot of people have not understood, and that explains some of the things that we are saying. So, Ajit, what about FMT? You didn't. What are your hard indications that you use in your unit?
Like after COVID, I mean, we didn't use it for 6 months or so. You'll be surprised to know that patients who have previously been on FMT, majority of them are coming back and say that we want FMT again. I mean, this I'm referring to pre-COVID era, that the patients who have been on COVID, on FMT, and we stopped because of COVID, and they have been wanting to be on FMT again. So again, patients who are not responding to immunomodulators and steroid dependent, we are using, but our use is not as much as it was pre-COVID era.
Usha, what's your thing? Is in PGI was the same or?
No, we haven't been using FMT very often, except in one patient who had a resistant C. difficile colitis. Otherwise, we are not using it as routine practice.
What
For
about
Naresh,
us
I have
also, it's the same.
Yeah.
Yes, Rakesh?
It's recently we had the CCF consensus meeting at Ludhiana, and just a month ago, GUT has published the Rome consensus on FMT. All the questions which we deliberated and which will come to our mind even now, today, are still left unanswered in this consensus. The first Rome consensus on FMT, starting with who should be an ideal donor, who should be an ideal patient, what should be the route of administration, how do you measure the response. So if you go through that, you will feel as if you are even at the beginning of FMT. So we need more robust data to have it in clinical practice. Yes, research centers like Ajit or Vineet or some others who have used it, including Devender, we are still a far distance from the actual clinical use. We need more data, and in our context, it is even more important. How do we, have the stool banking? Something very important, which was the most controversial topic discussed at the Ludhiana meeting.
Okay, quick comment from each of you on this role of EN and coconut water and things like that, which manipulates the microbiome. Do you see that it's got a bright future? First, Rupa.
I think the concept that microbiome is getting altered by diet and other dietary manipulation is going to come, because as we are doing more and more studies, we do find that there is a definite microbial signature for inflammatory bowel disease, including we have developed a machine learning model for identifying Crohn's disease on the basis of the stool microbiome. But having said that, the costs have to come down for its utility in day-to-day practice. But this is an area which will work.
Would you use it? Just say, would you use EN?
Yeah, why not? I mean, if I really feel that if coconut water is working, then there is absolutely no reason why in India we cannot ask people to have coconut water. Having said that, I'm also interested to see if that is working, then we can just give 1 teaspoonful of potassium chloride to a patient with ulcerative colitis, if that works. If it is the potassium, then supplementation can be in any form. And I think we really need larger studies, because if it works, then it's a very good option. Coconut water for all ulcerative colitis patients, and if are more severe, then we can just add a little potassium or at least monitor.
Devender?
So in Mumbai, 80 to 90% of the patient take coconut water after discharge. So earlier I used to say no point. Now I'm not going to say no.
No, Matthew and me are
microbiome, we will be keeping on seeing many studies and many reports coming. And I think there's a flurry of things that can be done. But over time, it will crystallize into more concrete clinical practice guidelines. I think right now, we are all doing a lot of work, and it makes a lot of sense to do those work. but it will crystallize slowly.
Sure. Do you use EN in your patients with UC?
Yeah, we do use EN, and we are right now conducting a study on the role of enteral nutrition as an add-on to therapy. I do believe that sustained EN over a period of time would change the microbiome to a more favorable microbiome. Regarding coconut water, I think we just have one study. We should be very guarded in, advocating it. Though coconut is a natural thing, there is also another component apart from potassium. I think there could be some medium chain triglycerides. There could be also certain products in that which have antifungal property and antiviral properties. So coconut water is a natural substance with some antimicrobial properties, which may also have a role in UC. I think we have to explore that before we just make it, people will start drinking Tetra packs of coconut water. I don't know whether that is sufficiently has the same benefit as a natural coconut water directly from the green kernel.
I think diabetics have to concern also.
Can I make a point?
Yes,
Matthew?
Matthew, then Rakesh can conclude.
See,
Yeah, I just wanted Usha to elaborate on the fungal microbiome. She had done a study, and the results were quite interesting, but not widely disseminated.
Yes, sir. Thank you. We did a study in 267 patients with ulcerative colitis and we found that those who are on steroids and those who are having active disease are having higher candida signature in the stool as well as beta D glucan levels in the blood. And those who were culture positive for candida in the stool, we randomized them to receive fluconazole. And we found that the group which received fluconazole in a placebo-controlled trial, in the randomized trial, that they significantly dropped their calprotectin and became more responsive and had higher remission rates and clinical response. So there is a component of bacterial, apart from bacterial issues, there could be also fungal issues in terms of candida. And what it has been found is that candida colonizes inflamed areas and sets up a pro-inflammatory state there. So removal of candida may help in tissue healing.
Rakesh? Want to summarize? Matthew wanted to say something and then Rakesh.
No, I just wanted to say, since you asked, coconut water is very common in Kerala, but unfortunately, I don't think people drink coconut water, but they take coconut. And second thing is, I don't just want to tell about FMT, my experience. Before COVID, we were using a little more frequently, but the response I have noticed is that it's not well sustained. But I was doing more of Crohn's and less of UC, but I found the response is better with the UC rather than with Crohn's.
Are there any questions in the chat box?
I didn't see any. I didn't see any in that chat box. Let's see. There's some few messages here. Let's see.
This session, there are so many questions, and still there are.
How long to give budesonide in someone intolerant to 5-ASA? Is there a role for long-term budesonide, or is only to get a remission? Isn't it?
Not beyond 12 weeks.
There have been some earlier studies on the other budesonide, the controlled release budesonide, and that had shown that you can give it up to 9 months.
Yeah, 9 months to 1 year is what.
9 months to 1 year. So I think if the patient has,
We are talking of different situations. One is for Crohn's, one is for UC. MMX
no, what
is
I'm saying is there have been some studies which have used it as far as side effect profile is concerned. There weren't any major reported. So
CR is not for UC. I mean, that was wrongly being used for ulcerative colitis.
No, I'm not saying it is wrongly being used. I'm just saying from the side effect profile part of it, in Crohn's disease, budesonide has been used for even up to 9 months. There have been studies which showed no major adverse events related to the long-term use. So if there is in this particular question a situation where there is a patient who cannot tolerate other drugs and other options not available, I suppose we have some evidence that it can be pushed up to that range. But I am absolutely clear about, yes, MMX preparation from UC and the other
No,
preparation.
no, no. I was not referring to you. I'm just saying we should make the answer clear.
Yes, yes, yes. Dr.
Sir,
Desai, you were also saying something.
And I have a question regarding MMS technology and its drug delivery in patients when there is rapid gut transit. So patients, when they come in with active colitis, when there's rapid gut transit, does MMX, tell us it promises an amount of drug delivery, but I think it may not be actually happening in real life.
But same with the MMA, this one, the 1.2 gram preparation. Many people say that the tablet comes out as a whole, which may be a ghost tablet or actual tablet. So I think that applies similar to all the preparations also.
I think something very interesting, which is going to occupy a lot of our mind in coming days, coming years rather, is artificial intelligence. The NEJM is launching a new journal, NEJM AI. Some other journals are launching separate journals for AI, and it is supposedly going to be multi-billion-dollar industry in the coming years. And in the context of IBD, it has I foresee a great role. You start with the genomic profile of the person, the microbiomic profile, the metabolic profile of the individual. You can probably, with that information, which is not possible humanly to do it manually, reach a targeted therapy for precision kind of therapy for an individual, which we have all been talking of. Who should be given FMT, who should be given, IL-23 blocker or infliximab. So this is something which many countries are investing a lot, and we are going to hear a lot about this. And as Rupa said, that probably they have set up a unit there. This is something very interesting, and starting basic diagnosis is going to be, you don't need anyone to do an expert gastroenterologist to do colonoscopy. Assistant will do sigmoidoscopy. You have the images and grade the disease, and with the biomarkers, you grade the severity and go on to a specific targeted therapy based upon the omics. So there's the role of AI, which I'm sure we are going to hear a lot about it.
I just wanted to come in here with Dr. Ajit Sood in CCF, whether we can have a nationwide database, a consortium of our IVD patients, just basic data into the system, and we start biobanking, we start doing things so that once technology comes in, we should be able to use it across population in a larger group of people, and also technology becomes cheaper when we use it over a larger set of patients. So, and also the IBD card, so that even when patient moves from one center to the other, he carries the basic information rather than every center starting off afresh with each patient.
Yeah, issues will be very, very nice points. The issues will be legal points and confidentiality. Now, can we really, the whole data of a person is exposed to others. Now, like Professor Kocher has very rightly said that AI has advantages, and I totally agree that AI has a bright future, and its medical IBD treatment is going to be AI based to quite an extent. But these legal issues and these safety issues are yet to be sorted out. And other things, like at the moment, machine learning is based on still images from endoscopy. What it needs is a live pictures of the live demonstration of the endoscopy findings, because still images cannot teach the machine the way it should be. So there are many points, as Professor Kocher said. We are far short of that, but it's very. This is one area where there's going to be a lot of research.
Yeah, I think even like, the little things that have already happened. So like for endoscopy, use of the endobrain. So we are using it in our hospital. I mean, at least for polyps. So in ulcerative colitis for all pseudopolyps, it just shows low probability, no biopsy, low probability, no biopsy. So if we're just going through, it just the value comes up. And for adenomatous polyps, it just says suggests biopsy. So that is just seeing in direct seeing. I think where we will need it is, as Dr. Kocher just mentioned, is for prediction of drug response. Now we'll have biologic, we have so many more coming. So I think with metabolomics and all those tough names that we have, and microbiome and other things, we have to use some machine learning algorithm which will tell us that you use this, and then we have to go by that in future.
I think,
Ajit, CCF should have, taking into account the confidentiality part, we should have a nationwide registry and an app-based program for the patient. The ownership of the confidentiality remains with the patient, and the treating physician has limited access to it. But for example, you have a patient who after 10 years should undergo a surveillance. The problem is he shifts from A city to B city, but if his records are available in the basic database nationwide, and it is not going to be at the government level, or it has to be at the level of CCF or ISC. So you should consider that very strongly. And the longitudinal follow-up will have unlimited data available, and ultimately reducing the cost of treatment for every patient.
I think you're very right, sir. We will definitely work on this.
Maybe IBD
come to the end. Yes, Usha, last comment.
Here, Dr. Sood, the IBD card, which was designed and also approved by CCF, if we popularize that, every patient carry a card, where even if he moves across the centers, he need not have re-evaluation at every center.
Yeah, I think very right. Actually, we do certain things, then we forget it. I think we are in that phase, so we have to wake up and work on this. But that is a good idea, Usha.
I think ISC should take the lead along with the CCFI to make IBD management much better in India. I think that is the best policy.
Yeah.
I think we'll stop here. We've exceeded time by about 15 minutes. Thank you, everybody. We have had a reasonable discussion on some day-to-day clinical issues, something to munch for the future. AI maybe is going to change things, but I think it's a little way off. I don't think it's anywhere close to be into hardcore clinical practice. Thank you, Ajit, for making this possible. And thank you, Rupa, Devinder, Usha, and Rakesh. Last comment by you, Ajit.
May I request Professor Kocher to present a vote of thanks?
Well, thank you, everyone. This was a very interesting session, and I think we have had best of DDW and best of UEGW, but this is something which is of interest to a lot of people, those who are caring for IBD patients. And I'm sure that in the coming years, as the CCF activities have picked up, this activity will continue and gather more steam. And I thank all the panelists, the two speakers particularly, Arshdeep and Saurabh, the moderators, my co-moderator, and the panelists, and particular thanks to CCF, Dr. Ajit Sood, for this wonderful initiative. Thank you, everyone.